Thank you everyone for coming today. I'm Alex Owens, I'm an analyst lead at Arden and GMCSU, and I'll just be running through, again, a picture of multimorbidity. I think probably the third talk I've seen on multimorbidity this week, so yeah, popular topic, but I think probably for a good reason. Hopefully I'll outline some of the reasons there as well. Whoops. So I'll be running through the session today, basically just giving an overview of how multimorbidity looks like in England at the moment, using some interesting novel data sets that maybe some people have seen, but hopefully we will continue. So the first question I think we probably need to ask is, what is multimorbidity? I imagine, given the number of presentations, that people probably have a good idea at the moment, but I think it's probably good to outline exactly what I'm talking about. So for multimorbidity, the World Health Organization is defined as the coexistence of two or more chronic conditions within an individual. For some of these slides, we've used long-term conditions, but it's kind of the same idea. It's people that have two conditions or more that are kind of dealing with the outcomes of those conditions and how they affect that. Something that I think we've been kind of dealing with since time immemorial, since humans have existed, is having two conditions that are kind of impactful, but not necessarily something that's going to be examined as well as we would have hoped within the NHS and within health systems in general. So current picture of the NHS and I guess World Health. So I've taken some quotes from the Academy of Medical Sciences, and they've published a paper called Multimorbidity, a Priority for Global Health Research. So you can kind of guess where some of these are going to go, I think. So the top one, or the first one, is in 2018, so a bit of ways away, but it's not that long in kind of health research history. Currently, there's no used framework for defining or more widely understanding multimorbidity. So the kind of the push of this paper is that this hasn't really been looked at historically too much. We focused more on kind of single track, single conditions, and not necessarily how they affect patients in their aggregate. It's become a more recent problem as people are getting older and are kind of developing more conditions. It's a benefit insofar as we've developed healthcare to a way that will allow people to get to that age and manage their conditions they have and survive. But there's also the negative in that as they survive longer, people pick up more conditions and then have to suffer with those conditions for longer as well. Second quote here is more on the research side. So most health research is kind of focused on the prevention and management of disorders in isolation. So I think that makes sense. We want to research kind of very specific areas, and looking at the number of combinations of conditions that people possibly have is kind of a very hard thing to do. But then it limits kind of how we can treat conditions as well. So if we have kind of diabetes and asthma in an individual, they pick both up at a young age. How do you treat that pair in combination is not necessarily examined as well. So medications may conflict, treatment regimens may conflict, so it may be kind of quite a troubling thing to go through for the individual as well as for the health system that has to manage those two needs. And the third part I've taken as well is in most parts of the world, large components are based mostly on some of these other single conditional body systems areas. So it goes back into the previous point. So the training of doctors, for instance, become more and more specialised. People go into their self-specialisation and will have the knowledge there in the initial training that they've kind of picked up from conditions, but won't necessarily have the context for all other conditions that come in, how an individual that presents with two or more might actually kind of react to their individual treatment plan. Those are kind of given over now to geriatricians, people in old ages to pick up conditions, and also sort of our general practitioners as well. So for younger ages, that will be the focus. So why is multimorbidity important? What are the negative effects it can have on patients? So this is another paper kind of what kicks a lot of this off in the World Health Organization. So one of the key things to think about when thinking of a person with multimorbidity is polypharmacy. So an individual that has one condition could struggle to manage their medication regime. If you add 2 or 3 conditions on that, it can be tough to get all the medications they need. Interactions between those medications, treatment plans, it can be hard to kind of keep them to things. Especially as they're kind of getting older in age as well and picking up more conditions, it can be a tough one to run through. And from the provider side as well, the pharmacy, the doctor understanding all the conditions and interactions between those medications. Second is a similar thing, but more on patient care. So as a patient comes into hospital, digital specialist that deals with the condition they currently have, that has kind of an emergency condition, understand necessarily how to treat that patient when they have another condition. Is there any special compensation they need or special dispensation they need for other conditions as well? And the last one, or the second last one, I think, is demanding self-management needs. So it's similar again to the pharmacological side, but more on the patient burden. If they have kind of a diet plan they need for one condition and a restricted food kind of management for another condition, it's going to be quite hard to juggle all of these self-management needs that kind of help with the long-term conditions themselves, but are a burden on that patient. And last one, as patients get older and kind of develop poor health, these interact negatively together and kind of lead to more conditions and more, and it just kind of spirals down. So good kind of motivations for tackling multimorbidity as a problem and understanding it as well, especially as kind of an analyst convention. It needs to be something that's talked about when undertaking analysis. So the context of why we're looking at multimorbidity today, or why I was previously and am now presenting to you, we were doing some work with the National Diabetes Programme on evaluating their NDPP platform, which is kind of an exercise regime that helps manage diabetes or stop pre-diabetes progressing into diabetes. Part of that was looking at how that programme affects in other individuals with multiple conditions, and how they start picking up conditions as well. So part of that is going to be gone into here, but mostly it's just going to be to look at the baseline of how multimorbidity affects it. So I guess one of the things is this: how do we identify someone that's multimorbid? That hasn't always been looked into too much. We haven't necessarily had the resources to pull out and say this person has this condition, this person has another condition, and we've kind of gone about it in a way that's been not necessarily unique. I think I've seen a lot of people talk about kind of linked data sets, patient data sets here. We've kind of pulled together, or we've received from Health and NHS England for now kind of commissioned this data set from a company called Healthcare, called the Bridges to Health National Segmentation Data Set. So this is kind of a person level data set that is totally pseudonymized, but then tracks the condition the patient has through monthly snapshots. So if a patient kind of comes in since 2017 or 2016, I think, so monthly snapshots made in 2016 up until August 2021 currently. So with this, you can build kind of a picture of health that's, I guess, somewhat associative. You can see when someone picks up a condition, kind of further on down the line, then how that progresses in other conditions here as well. This provides a very powerful tool to look into kind of the relationship between those conditions and their acquisition. I think I'll kind of jump into a bit later. It allows us to identify the exact month the patient picks up a condition, but there are a couple of caveats. So one of them is a lot of the data is based on secondary care data sets. So it's when a person presents to an acute kind of setting, so hospital or outpatient facility. So certain long-term conditions aren't as well covered as we want. There has been some work to remedy that, and I'll show a slide next, kind of coming up with the data sets that are used, where they've gone into the National Diabetes Audit and picked up some general practice data for diabetes, and kind of done some work with hypertension, which is less likely to be diagnosed in secondary care. And it also doesn't deal with remission. So once a patient comes in with a condition, they will have it for the rest of their time on that record. So this is how this data set is built up. So we can pull together for patients geographic data. So if we want to examine a specific area, we can look at that. Social demographic data, so we want to look at multimorbidity by some of these bits and pieces which we will do. So age, gender, ethnicity, deprivation. We can kind of dig into that a bit deeper as well and see the disparity between groups. And then it pulls together all of these segments, which are large, but these segments are kind of made up of these subsegments of conditions. So they inform kind of a wider grouping of patients as well. So quite a lot of conditions here. I think 36 is one we were looking at, but there's a lot of kind of different severities of conditions as well, which we've condensed into one. But a quite wide range, so some mental health conditions, so depression and serious mental illness, a lot of cardiovascular, so bits and pieces like chronic heart disease, and then bits and pieces of aging, so osteoarthritis and osteoporosis, and also some learning disabilities as well on there. And this is the set of data sets, quite a big one, but most of it again is based on this MPI data. So there's some flaws there insofar as if you have a patient on the MPI that doesn't exist, they will carry on forever, which might show up a little bit later. But otherwise, it's quite a good data set for understanding population health in snapshots. So most of them taken from SUS, but then backed up by kind of emergency care, community health, mental health data sets, and then the National Diabetes Audit as well for diabetes data. So I'm going to run on to the analysis, but fingers crossed by the end of this you'll have brief detail into long-term conditions, so you can't really look at multiple conditions without understanding what the landscape for individual conditions are at the moment. Then we'll look into kind of broad population demographic of multimorbidity. And then we have a lot of conditions, but I'll deep dive into two specific conditions that have a little bit of a different presentation and look at kind of how they are interacting with other conditions as well. So individual long-term conditions. For August 2021, there were 19 million individuals with long-term conditions. This is an area chart that kind of shows which are the most prevalent long-term conditions. with kind of everything else written down. So you can see that we've got the asthma, depression, hypertension, diabetes, arthritis, it's quite a lot of chronic heart disease. And most of these will be kind of burdens in the elder age population as well. So it's quite an interesting kind of look at what long-term condition landscape looks like, just by kind of what's occurring most often. This is by age, so again, maybe a more important look without kind of fixing it to the elder ages or biasing to the elder ages that are going to present more conditions. This is proportionally by age, a little bit of an easy view of the rescale, but I just wanted to show that the younger ages really don't have a huge proportion of patients with long-term conditions. It's kind of mostly other than the elderly. If we switch over to our rescale graphs, you can kind of see the very different conditions presenting. So a lot of asthma in the younger ages, a little bit of depression starting on the teenage years, some physical disabilities and autism, but mostly asthma there. 2024, yeah, more depression, still a fair bit of asthma, but type 2 diabetes they're moving in. And then as we get into 45 plus, so it's seeing hypertension and some of the cardiovascular diseases. So 45 is depression, mostly with hypertension following up. 60 to 70 will be hypertension, some diabetes and coronary heart disease coming in. Cancer there as well at 9%. The 80 plus will be mostly hypertension, osteoarthritis, and coronary heart disease. So quite interesting spread throughout as you age, like the types of conditions you get change quite a lot. So kind of interesting to look at. So performed a linear regression, so regression model on the data to look at if they acquire a condition in the year, so kind of predict for that, but then will help us descriptively understand which of these influences actually pay out onto that. So which of these demographic influences will help describe the long-term condition gain within a year. So by the analysis we did, it seems that age plays by and large the biggest impact, which is not particularly surprising as you age. You're getting more long-term conditions and you're more likely to gain one within a year. The number of LTCs you have as well, so the number of previous long-term conditions. As you have more, you're more likely to accumulate more and more as it's going. Seemingly, sex and ethnicity, once we've also accounted for deprivation, didn't have a huge effect. So 1.03 odds if you're female over male, and then 1.02 odds if you're black over white and Asian. So once you've kind of included that deprivation lens, that doesn't have a huge effect. And deprivation did seem to have quite a large effect on acquiring a condition within a year. So it's kind of one cell reference at the most, at the least deprived, and then your 4.36 higher odds of getting a long-term condition if you are most deprived. So we have an interesting demographic there of how people acquire conditions. So more into the multimorbidity side now. This is a graph of people by ages and how many conditions they're likely to acquire. So if you look at the total graph, that would be the entire population of England. And there at the end, I think, is our dip that I mentioned earlier, where people that are incorrectly registered to the MDI kind of surviving in zero conditions. We've got a bit of a decrease in long-term conditions there. But yeah, quite a stark picture of kind of the number of conditions people have and how they kind of suffer with diseases over time. So for the population of England, 70% of them are healthy, they have zero conditions. For zero long-term conditions, they might not be as healthy as that represents, but they will be kind of there. 15% have one condition, which leaves the rest of our morbidity, so 60% 2, 4% 3, 2% 4, 5%, 4% 5, sorry, and 2% 6. So if you have a long-term condition, you're equally likely to have more than one or be multimorbid. You would be to be having a single long-term condition too. It affects a large portion of the population, which is kind of something that needs to be looked at and understood to some degree as well. If we focus on people that are 60, again, kind of running through this is kind of where the balance tips. So we have about 50% of people having zero conditions, 22% one, and then again, multimorbid, we run through and get 60-year-olds who are multimorbid, which is again quite a shockingly high number. So half of those people will have more than one condition and will have to have special dispensation for how that's treated, or just have to have some understanding of kind of the journey they're having with having two of those conditions. Another one to look at, again, I hinted at earlier, but deprivation and how that affects morbidity. So a similar age graph again, and this is the proportion of people that are multimorbid by IMD-SR. So IMD is index-morbid deprivation. 1 is going to be the least deprived, so people that are kind of more well off. A 10 is going to be those people in the most deprived areas. Again, going to our 60 to 69 group, it's quite a huge difference in impact there. So 23% of people that are the least deprived have two or more conditions, so they're not morbid. But if we look at the people that are the most deprived, that's up to 42%. So that's a difference of 19 percentage points. Again, quite a huge gap on how deprivation impacts picking up conditions and retaining them. And again, goes to show that the people that are kind of most deprived have some of that larger impact in healthcare when dealing with those two conditions. A look at spend as well. So one of the benefits of this data set is it allows us to link through to some of the sales data and pull out kind of their acute spend. So this is average acute spend by patient, by condition. I've got another view of this which might be easier to look at. Because it's a somewhat surprising view in that it seems to be the 0 to 10 have more spend at those higher condition count levels, which is somewhat understandable insofar as infant care is a lot more complicated than geriatric care, which would be kind of more normalised. But at the lower end, so those 0 LTC counts, 0 to 10s through to 80 plus seems to be kind of a linear relationship. So a switch on view for how that's looked at. You can see this is the other way around, so you get the LTC count at the bottom, then going up by age. So you can see 0 seems to be like a bit of a curve there. 0 to 1, you start getting the U-shaped curve, which is kind of quite common when you see kind of expenditure by age. And you see people that are younger tend to have a higher cost, but then dips down in middle age and then up again at the end of it. And seems to kind of carry out up until 6 plus. This is another one that's interesting to look at, so commonly occurring conditions. So the more popular conditions they're popular, the more frequently obtained conditions there's hypertension. Has been highlighted in blue, just to show kind of how prevalent that is occurring in other conditions. But they seem to have kind of some level of theme for hypertension and cardiovascular disease seems to be quite high up in the governments. With moving down, kind of getting more diabetes, things like that. It's quite a kind of, again, interesting view as to what conditions are putting together, or maybe a priority list for when we look at which conditions to tackle and which conditions to advertise. Doctors or analysts say look into this in a deeper lens for how best to treat these people. The first ones to weigh out, I guess, would be the ones that are often co-occurring. Probably there is already a fair amount of work. So this is again the condition deep dives. So a bit of a different look rather than just looking at the everything. You focus on the condition and see what common pairs are there. So with diabetes, the chart on the left is the age you pick up diabetes in the red band, and those with just multiple LTCs that include diabetes in the second. So you can see you pick up diabetes from a little bit earlier, but it progresses. You pick up your second condition quite soon after. So the pumps kind of follow each other quite closely. This will change for the second condition, a little bit different. So the second condition will be asthma, and that will kind of an interesting difference to focus on that. For diabetes and comorbidity with other long-term conditions, quite a lot of people with diabetes have another condition. So only 70% of people with diabetes have just diabetes. This kind of increases for other conditions as well. So 20% will have one other condition, 19% two, and then the rest will have more. So again, that would be a huge burden on health for those people. Another interesting thing to look at is potentially the number of conditions or the proportion of people that will acquire a condition in 1 year, and which conditions those are. So if you have diabetes, you have a 4% chance of acquiring hypertension within 1 year. So looking at people with just diabetes and what they're likely to obtain in 1 year. Osteoarthritis, you have a 1% of obtaining osteoarthritis in a year, about 1% for coronary heart disease, 1% for cancer, and the other under 1% for depression. So it's kind of quite commonly occurring comorbidities with diabetes. And again, looking to cost, you can kind of see that the impact of diabetes across the someone just diabetes is displayed there at the top. And then the 6 most prevalent conditions by risk ratio, and then just by raw numbers. So you can see kind of how it interacts with other conditions as well. So diabetes and hypertension, for instance, is a lower interactive cost than high fibrotic risk, which would be an inherently higher cost. And the activity as well. So activity context is also an important thing to look at. The path of morbidity, so this is looking at diabetes and cardiovascular diseases. So the number of conditions you're likely to pick up with diabetes before the end of your life is quite high. So someone with just diabetes will have a 10% chance to pick up at least one condition, all the way through to nearly 25% chance to pick up 3 other conditions. Again, quite a shocking kind of display there. And that's again potential people that getting those conditions in the lifetime second side. So diabetes would be 100. If you have diabetes, you've got to get diabetes. Then 80% of those people will also get hypertension before they die. One more onto the order of conditions picked up. So this is the most likely combination of picking up diabetes and another cardiovascular condition. So this is kind of which are the most likely to pick up. So at the top here, you can see 12% of people will obtain diabetes, will obtain hypertension and then die. 10% of people will obtain hypertension, will obtain diabetes and then die. So that's kind of showing that you're more likely to have hypertension and diabetes than just diabetes alone. And then 3% additional conditions as well. So 3% of people dropping down there is diabetes, hypertension, and then cardiovascular disease and die. Again, I won't leave this up too long, I think I'm running a bit short on time, but the second graph again is the look of people that don't necessarily die, but then the order of the conditions. Last one, to deep dive into is asthma. So a bit of a different condition here in this, but mostly picked up in the younger age. So you can see the age graph here. Most people pick up asthma and go for quite a long time without picking up a second condition. You can see that 50% of people with asthma already have asthma. But again, as they start getting on to other conditions, you get about 50% of those people have multimorbidity for one of the condition at least. For conditions with asthma, you're more likely to pick up depression. Hypertension is less likely again, so 1% depression versus 4% hypertension last time, down to only 0.6% hypertension. Osteoarthritis, cancer, COPD. And again, this is the cost breakdown, activity breakdown by asthma. So asthma is quite a high cost compared to diabetes, but it interacts kind of with different sets of diseases because they're more commonly co-occurring. So depression and asthma, for instance, don't have a huge multiplicative effect, but if you look at severe interstitial lung disease, that'd be more frequent, or more cost and then more frequent visits. So I guess some looking into how we get better at exploring conditions in context. A wider breadth of scrutinising on presentation multiplicity, I think it's probably just understanding where things lie and what the landscape is, would help us a lot in how we treat these. So kind of more deeper dives into conditions, common conditions, and understanding of how things move. Allow the individuals to prioritise areas and inform policy. So again, that kind of falls through. So if you want to do your local level, understanding of what your local population is likely to have in terms of multimobilities, and also at national level, where those focuses should be. Kind of some of the takeaways from here is to maybe think about that when you're doing your next week's analysis for analysts. And then areas of here, drilling down again to those local areas and understanding what that picture looks like. It's much different from national, and then what's driving those differences. And then further areas of research for support pathways. So kind of how this turns research into what we need to understand as well. Attribution and collaborators, so these are the people that supported through this work and then also around it on the diabetes program. And our ongoing presentations, we are currently in CMO9 to talk to for any of these presentations. And we have upcoming presentations by Sonia and Adrian, who's doing something that's expansion on this, going down Markov chains. Any questions?